Another clinical correlation is antiphospholipid syndrome. Now, platelet factor 3, like I said, comes from platelets, and generally there is a phospholipid carrier, another molecule that helps bind to platelet factor 3, and it makes it unavailable to activate the other clotting factors in the intrinsic pathway. However, with antiphospholipid syndrome, a patient makes antibodies against that phospholipid carrier, shown here in the bottom right picture with the little black Pac-Man attacking the phospholipid carrier. So as they bind to it, they disengage the platelet factor 3, making it available to activate all the other downstream clotting factors, like clotting factor 8, etc., to generate the PAS, prothrombin activating substance. So this is going to lead to hypercoagulation. That means reduced clotting times, a higher tendency to clot. This is particularly dangerous in women who are pregnant. Oftentimes they spontaneously abort their fetuses because this is happening so much in their bloodstream that they are frequently put on heparin. But it's not uncommon for a lot of women with this syndrome to have multiple miscarriages before their problem is diagnosed. All right, thrombocytopenia, or idiopathic thrombocytopenia purpura, as it's known. I'll remind you, penia means too little. In this case, we're talking about reduced thrombocytes, less than 100,000 platelets per microliter. The patient will present with petechiae. These are small little purple blood spots just below the skin. Why do those form? Well, we have lots of micro tears in our vasculature, and if we don't have enough platelets to form a platelet plug and start the clotting process, then the blood will seep out of the blood vessel and into the interstitial space, creating these tiny little red dots. If the little red dots, the petechiae, are larger than 1 centimeter, then we say that they are purpura. We don't always know if there is a cause. This can be just spontaneous. It can be autoimmune, in which case IgAs or IgGs can target platelets for destruction. It could be a result of viral infection, but it's certainly more common in young females than in young males. And again, most autoimmune disorders are more common in females. It can spontaneously resolve, but if it doesn't, we then do a splenectomy. And why would we do that? Well, the spleen is one of 2 places, the liver being the other, where platelets are removed from circulation when they get too old. So if you remove one of the places where platelets are removed from the bloodstream, then that means they'll last longer in the bloodstream. We don't remove the liver, just in case you're wondering. A person needs their liver to live, but they don't need their spleen in order to live. Moving on to more clinical correlations is hemophilia. Signs and symptoms of hemophiliacs include bleeding in the joints, easily bruised muscles and soft tissue. If they lose a tooth, they can bleed excessively. Females who are hemophilias, when they start their menstrual cycle, many of them died back in the older days before we had some ways to prevent the excessive bleeding. They can present with blood in the urine and blood in the stool. Anyway, classic hemophilia is a problem with factor 8. And of course, remember Queen Victoria and the Russian family, the Russian royals. There was a genetic mutation, and Queen Victoria was a carrier, shown here in the bottom pedigree. And what you're seeing is every time you see a square, it is a square or a circle that's fully colored in red. It represents a person with hemophilia. And if you look at this, there are squares filled 100% with the color red. And these were males. Squares represent males. And the females are represented by circles. So we don't see any females on here that had hemophilia, but that doesn't mean that they couldn't have it. A female just simply needs 2 bad genes in order to present with it, because factor VIII gene is actually found on the X chromosome. So that means with a female, we have 2 X chromosomes, but we only use 1. A male only has 1 X chromosome, and therefore if their only X chromosome has a genetic defect for for factor VIII, then they're going to present with a disease. And I'll show you the genetics in just a little bit. Hemophilia B, also known as Christmas hemophilia, is less common, but it is a deficiency of factor IX, which its gene is also found on the X chromosome. I have up here von Willebrand disease. It is not hemophilia A nor hemophilia B, but persons with von Willebrand's disease will present as if they have hemophilia A, because von Willebrand, I'll remind you, needs to carry factor VIII. Without von Willebrand, factor VIII is free in the plasma and has a high destruction rate because it's not being protected by its carrier protein. So let's review the genetics of this. As I said, with females we have 2 X chromosomes and males have a single X chromosome. For both factor VIII and factor IX, the genes for those factors are found on the X chromosome, as shown up here as a little red box. The Y chromosome is very short, and it is genetically void of gene. Well, it's not void, but it's like a barren wasteland. There are very few genes. The most notable one is the SRY gene on the Y chromosome, which codes for testicular formation. So it is more common for a male to have hemophilia than female because they only need 1 bad X. For females, because they have redundancy, in order for them to present with hemophilia, they would need to inherit 2 X chromosomes with the mutation. So shown here, we have on the left side 2 parents. We have a father with hemophilia, which apparently he survived long enough to procreate, with a mother who is normal and healthy. If we look at their chances of producing sons and daughters, we recognize, of course, that there's a 50-50 chance for a son or daughter. That means 50% of their children should be male and 50% should be female. Of the females that would be generated, all of them would be carriers. Why is that? The mother, who has a normal X chromosome, both of them are normal, would donate a normal X chromosome in her oocyte. The father, when he develops sperm, can only donate his bad X chromosome to his daughters. So they would be carriers. But any sons they have would be just fine. Why? In order to create a son, the father must have the sperm with the Y chromosome fertilize the oocyte. It's the father that determines the sex of the baby. The mother, who's normal and healthy, can only donate her healthy X chromosomes without a mutation. But if we look in the next scenario, where the mother is a carrier, we recognize that she can develop oocytes with either her normal X chromosome or the X chromosome that is carrying the mutation for hemophilia. In this case, 50% of their sons that are born will have hemophilia. It's a 50-50 call which X chromosome they're going to inherit. 50% of the daughters they have will be a carrier. And again, that is dependent on a 50-50 chance of them having the oocyte that has the bad X mutation on it. I'd like to finish up with a brief discussion on disseminated intravascular coagulation. This is basically a vicious cycle of abnormal bleeding and clot formation. So the coagulation step starts first. The coagulation and the clotting is very, very uncontrolled. And this can be because of tissue that's been damaged, like say to a crushing accident, or maybe there's necrosis, or maybe there are some toxins leading or poisons in the blood that's poisoning the tissues, or maybe a placenta has a minor tear in it. But either way, cytokines and factor 3 released from the damaged tissue are going to target the clotting factors. It's going to be the extrinsic pathway that starts this. So you get the inflammation from the poisons, from the blood, targeting the tissue. The tissue starts to release its tissue factor 3, which is phospholipids and some proteins. And next thing we know, we've got the extrinsic pathway forming a clot, and the extrinsic pathway will target the intrinsic pathway, and then we're going to get a lot of clot formation. Well, pretty soon all those clotting factors are rapidly depleted, and the plasmin starts to chew up the clot. Next thing you know, you've got bleeding out into the tissues. So that's what I mean by abnormal clot formation and bleeding. There's a whole bunch of clot formation and then dissolution, and then the person has no more clotting factors left for more clotting, so they bleed out. The type of DIC that we see in pregnant women is given a slightly different name. It's called HELLP, H-E-L-L-P, and this stands for hemolysis, elevated liver enzymes, and low platelet count. It is the most misdiagnosed complication in pregnant women, and I'll put a paper on Blackboard for you to read. Basically, it's associated with preeclampsia, where the woman gets hypertension and then the placenta can basically disengage from the wall of the uterus and can lead to a spontaneous abortion, a miscarriage. Now, it is difficult for physicians to rule out if the preeclampsia always goes with the HELLP, or if preeclampsia and HELLP are two totally different clinical issues. But a lot of women with HELLP do certainly have preeclampsia before they show overt signs of HELLP. There's a very high mortality rate for the infant, again because of spontaneous abortion, about 60% of them. And the mother also can have is at risk of death because, again, she's going to have this rapid lysis of red blood cells and also a low platelet count. So all of her clotting factors get consumed and then depleted very quickly. I have a student currently in my physiology class who had HELLP when she was pregnant with her twins, and her physician, her OB-GYN, was astute enough to actually detect it, diagnose it, and make sure that she was on bed rest and was being monitored for her clotting times. Truly remarkable. She's healthy and her twins are healthy and everything's good. Well, that concludes our discussion on platelets. I forgot to mention that platelets also, of course, play a role in tumor metastasis. I'll remind you just quickly now that when a tumor metastasizes from its original site into the bloodstream to find a new location, it's going to be easily targeted by the immune system. And so the tumor actually covers itself with platelets to evade the patient's immune system so that it can find a new place to take up residence in the body. Okay, I'm looking at my quick little study guide here, and it looks like I've hit everything. I hope you enjoyed that lecture. If you had me for physiology, it was largely review, but nonetheless, I hope you enjoyed hearing it again. Okay, moving on to red blood cell disorders.